Hello, welcome to session 4, which is on common childhood diseases 1. Communicable diseases continue to be a major health problem in Ghana, especially among children. In today's lecture, we are going to look at some of the communicable diseases. We'll look at whooping cough and diphtheria. That's the reading list. Whooping cough. Whooping cough, or known as pertussis, is highly contagious bacterial infection caused by Bordetella pertussis. In some countries, the disease is called 100-day cough or cough of 100 days. It is more common and serious in infancy and early childhood. Mode of transmission is by direct or close contact with the mouth or nose secretion, and indirect by articles of freshly soiled secretions from an infected person. The incubation period is 7 to 14 days in infants or young children, but more than 3 weeks. So infants and young children can incubate it for 7 to 14 days, but it can also go beyond 3 weeks. So let's look at the pathophysiology. The causative organism causes a release of antigen and toxins, which cause pathological changes in the respiratory tract. Those changes result in attachment of pathogens in the respiratory epithelium and destroys the epithelial cells. So as a result, there is a disrupt of mucociliary clearance, and the inflammatory response leads to the production of phlegms, which is responsible for most of the clinical manifestations. It is divided into 3 stages. Look at the first stage, which is the catarrh stage. This is the most infectious period and lasts for 1 to 2 weeks. So it means that when you come into contact with somebody with pertussis and the person is in the catarrh stage, he can easily infect you. The onset is insidious. Fever may be minimal or present. There is mild respiratory symptoms such as irritation, cough, irritating coughing, sneezing, or runny nose. There is also lacrimation, and the cough does not improve in few days. We are expecting that the cough should usually improve in few days, but in this case, it does not improve in few days. Then we move to the next stage, that is the paroxysmal stage. The cough comes in spasms and usually in bouts, initially during the day, usually during the night, and later during the day. During the cough, you see the child's face becoming red, the patient looks suffocated, the tongue protrudes, he looks anxious and confused and restless. There is also sweating, congestion of the neck and the scalp vein. At the end of the bout, the child takes in a deep breath, and there is a prolonged croaking sound, which is called whoop, and is produced by the air entering the glottis. Sticky secretions come from the nose and the mouth, and very often the child vomits. The child actually looks exhausted after the bout. Babies usually present with apnea, cyanosis, and vomit mucus. There's usually no whoop in a baby. A longer period may result in death for the babies. In between the attack, child looks well, unlike other respiratory conditions. So it's actually during the attack that you see all those symptoms. After that, the child is okay. Chest examination is normal, except some rhonchi. The attack in this stage can be triggered by yawning. So as the child is yawning or stretching, laughing, yelling, eating or sneezing, or in a cold air, then the attack is triggered. A gradual transition then occurs. Then the child moves to the next stage, which is called the convalescent stage. In this stage, the bouts of cough decrease gradually over weeks. Vomiting becomes less frequent, and general condition and health gradually improves. So how do you diagnose? Diagnosis is on the history of whoop cough in the family or the neighborhood. Then you can take a swab for culture, you can do a blood count, ELISA test can be done, and chest x-ray as well. Management, you isolate the child, and you also give oxygen to children who have spells of apnea or cyanosis. Airway management, during the cough, place the child down or side to prevent inhalation of vomitors. Then position the child to relieve respiratory comfort. If a child is cyanotic, clear secretion and gentle suction. You have to give the child adequate nutrition and hydration, but you try as much as possible to avoid dry food such as biscuits and bread. It might precipitate the attack. Management, you give erythromycin to the child for 14 days. That's 40 to 50 milligrams per kg 4 times in a day. You can also nebulize. If nebulization is not possible, salbutamol can be given. You don't give cough suppressant. You don't give, it should be antihistamines and so on, should be avoided. Then you give adequate fluid intake and observe personal hygiene. This condition can be prevented. So let's look at how it can be prevented. The primary method of prevention is vaccination. We also have prophylactic antibiotics. That's erythromycin can be given to those who have been exposed or at risk of the condition, such as infants. The disease can lead to otitis media. It can lead to collapse of the lungs, emphysema, pneumonia, convulsion, encephalopathy, malnutrition, hemorrhage, hernia, and rectal prolapse as a result of the frequent cough. So that is that for pertussis. We'll move on to our second topic, which is diphtheria. What is diphtheria? Diphtheria is an acute infectious disease caused by the bacteria Bacterium diphtheriae. Mode of transmission, just like other respiratory tract infection, spreads through respiratory droplets of an infected person through talking. So if you meet a person with diphtheria, yes, you are talking to the person, the likelihood that you're going to have the condition is very high. Coughing or sneezing is also a mode of transmission. Diphtheria can be spread by contaminated objects or food, such as contaminated milk. Incubation period is usually 2 to 6 days. So let's try and see whether we can understand how we get the clinical features. Or let's look at the how the clinical features comes about. The bacteria most commonly affect the nose and throat. The throat infection, when it gets to the throat, it causes a gray to black tough fibre-like covering, which can block the airway. That makes the condition very, very serious. In some cases, diphtheria may first infect the skin, producing skin lesions. Once infected, the dangerous substance called the toxins produced by the bacteria can spread through the bloodstream to other organs, such as the heart, and cause significant damage. So this is the tough fiber-like covering in the throat that I was talking about, the gray to black pseudomembrane. So that is what we see here. Here, that is the, it can actually obstruct the airway. We have types of diphtheria. We have the nasal diphtheria, we have the facial diphtheria, the laryngeal diphtheria, other sites that may be involved to the skin, the ear, the eyes, and the genitalia. So look at the clinical features. The clinical features, it depends on the site of lesion and the location of the pseudomembrane. But the onset is acute with fever, usually around 39 degrees Celsius, very high. The child has malaise, has headache, has anorexia, has delirium, and is what? Drowsy. So the first one is the pharyngotonsillar diphtheria. This is the most common type in children, and it presents with what? Sore throat, difficulty in swallowing, muffled voice, low-grade fever, tachycardia, prostration, redness and swelling of the fauces, and formation of whitish gray pseudomembrane. We have the laryngeal, which affect the voice become hoarse. Sometimes you can't hear the person talking. There is croup, there is brassy or hacking cough, there is restlessness, there is prostration, there is dyspnea, there is chest retraction, there is lymphoadenopathy, edema of the neck, and formation of the membrane over the larynx. The membrane may cause respiratory obstruction or failure. So I mentioned that there is edema of the neck. So this is an image of a patient with edema of the neck, and is usually termed as bull neck. So as you can see here, all the side is swollen and it looks like a bull. That is why it is termed as a bull neck. We'll move on to the nasal diphtheria. This is very uncommon but important source of spread of infections to the others. Unlike the other ones, this one is uncommon. It is the mildest type and may spread to the pharynx. It is the mildest type and may spread to the pharynx. It can be unilateral or bilateral. It is presented with serum and blood discharge from the nose. Then you see excoriation of the upper lips with minimum toxic features. Diagnosis: you take history from the patient or from the parents of the child. Then examination of the mouth. When you examine the mouth, you may see the gray to black covering or pseudomembrane in the throat. You can also see a large lymph glands and swelling of the neck or larynx. You can take throat swab for CS. Then you can do electrocardiogram. Management: hospitalization is very important. With such children, you can't keep them at home. They need to be hospitalized and observed. Diphtheria antitoxin is given as a shot into the muscles or through an IV. The infection is treated with antibiotics such as penicillin and erythromycin. Oxygen can also be given. We should ensure the patient has enough bed rest. the patient should be given easily digestible and high caloric diet. Then antipyretic is given because of the high temperature. We also want the patient to sleep, so we sedate the patient. For the very ill ones, you give IV fluids, and NG tube is passed. For feeding, you have to monitor the heart because it can actually travel to the heart. Then insertion of a breathing tube if necessary for the very ill ones, and tracheostomy for airway obstruction. Then you correct all airway blockages. The disease can be prevented through childhood immunization. Anyone who has come into contact with infected person should receive immunization or booster shot against diphtheria. Then protective immunity lasts for only 10 years from the time of vaccination. So it is important for adults to get a booster vaccine every 10 years. Complications, as I said, the infection can travel to the heart, so it can lead to inflammation of the heart muscles. That is what? Myocarditis. The nervous system is also frequently and severely affected and may result in temporal paralysis. The diphtheria toxin can also damage the kidneys. So it is important that we actually detect this condition early so that we can manage to prevent all these complications. So you are expected to read on these ones. Some of them you can refer to NURS 243, that is prevention and control of communicable diseases. So today we have been looking at diphtheria and pertussis. We have looked at the causes, the pathophysiology, the clinical features, and how it's been managed. Thank you.